Comparison is challenging, but in second and further line, there is some uncertainty because the, the the FDA approval of the first line combinations have made some of the data that was produced around the pre-IO era somehow not relevant to the clinical setting right now. So we have so much data in first line setting, but in the second line setting, prospective data is limited. We have some data with Axitinib perspective and the strong and very promising data with Pembrolizumab in the phase 1/2 study that reported a progression-free survival of 11.3 months, I believe, and an objective response rate above 50% with this combination after immunotherapies. So in a clinical setting, the decision is based on generally the guideline recommendations, and guidelines currently recommend suggesting and discussing with the patient possible options, obviously a clinical trial and enrollment. And if that is not possible, a targeted therapy that the patient hasn't received in the past. We have also the results of studies with salvage, nivolumab and ipilimumab following immunotherapies in first line and after progression of disease. We have a lot of retrospective studies such as ours that give some data about the landscape, but again, we will need to wait for the results of large phase 3 randomized prospective studies. So in prospective setting, it is really challenging to conduct sequencing studies, looking at first line distus agent followed by distus agent in second line, due to the need for duration of follow-up and several other challenges. So retrospective analysis like that could inform authorities that design these studies in a way to develop most clinically relevant study for the future. Another point that we could contribute with the study is the adverse events and the safety of this combination, given that this is an off-label use that we present here in the study. The adverse events rates that we have seen with this in this report is also important in decision making when designing clinical trials in the future. Second and further line, I believe we do not have any study that compared two agents, one being Pembro-Axi combination. But in our study, we had this patient group that received nivolumab, ipilimumab in first line and received Pembro-Axi in second line. We had a very small sample size. In this group, we only had 17 patients. But again, we had a slightly longer progression-free survival and a higher response rate compared to the rest of our cohort. So in line with the guideline recommendations, I think administering a targeted therapy that the patient hasn't received in the past is beneficial, but the question is whether to add an immunotherapy and whether the efficacy could justify the potential adverse events. In our study, we didn't see any safety signals, although it's very small and retrospective. But with the CONTACT-03, TINO-02, we'll have a better idea regarding the sequencing of therapies.